Good afternoon, and welcome back to Health Leaders, the Winning Edge program, a series of webinars touching on the topics and strategies that you need to know most. My name is Chris Cheney. I am the CMO editor for Health Leaders and will serve as your moderator for this session. Today's webinar is titled The Winning Edge for Clinical AI Advancement. Thank you to you and our audience for participating. Before we get started, for those of you participating in the live program, I have a few housekeeping details. Note that an on-demand version of this program will be available on your YouTube channel on Friday and can be accessed through our website, healthleadersmedia.com. To ensure that you can see all the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC speakers for optimal sound quality. Next, you will find a resources list for today's webinar on the upper right side of your screen. Here we have listed the webinar slide deck and some additional materials for you to download, along with a registration link for future The Winning Edge events. At the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the Q&A portion of the program. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. At this time, it is my pleasure to introduce our featured panelists for today's discussion. James Blum, MD, Chief Health Information Officer, University of Iowa Healthcare, and Linda Stevenson, MBA, Chief Digital Information Officer at Fisher-Titus Medical Center. Thank you both for joining us. And with that, let's get into our discussion. Let's start off with having each of you tell us a little about yourself and your organization. And Linda, why don't you go first?
Sure, thank you. It's so great to be here today. As you said, Linda Stevenson. I'm at Fisher-Titus Health, which is a rural healthcare organization in Northwest Ohio. We are a single hospital, but pretty wide in terms of our services, everything from birth to end of life, including nursing home, home health, skilled nursing, etc. Our own EMS facility and about 20 other physical locations of ambulatory. So really excited to be here kind of representing this rural health contingency. And as of last month, I'm not only CIO, but also COO for the organization. So really have a little bit more of that clinical focus we're talking about today.
And Jim?
Yeah, thanks for the introduction, Chris. I'm Jim Blum. I'm the Chief Health Information Officer here at the University of Iowa. We're an academic medical center with 3 facilities in central eastern Iowa. We are about a $4.5 billion enterprise. We really provide tertiary and quaternary care for a good portion of the state of Iowa. My background is I'm an formally trained computer scientist and a physician. My practice is in the ICU and operating rooms. I'm an anesthesiologist intensivist and continue to practice today. And predominantly inside the organization, I have oversight over our clinician-facing IT applications and AI for the organization.
Excellent. Let's get into our discussion. When integrating a new AI tool into clinical care, who is brought to the table to lay out clinical and financial ROI? And Jim, why don't you start first?
Yeah. I think that, for us, in terms of introducing clinical care, we try to bring our clinician stakeholders to the table first to make sure that we're solving a problem with the technology that they actually need resolved. I think really that's where we start our discussion. And then once we made sure that we're solving a problem that actually needs to be addressed, we start to bring other folks to that table. Obviously, we get our chief financial officer engaged very early in that. Ancillary clinical services that may also take advantage of the technology, in addition to our IT teams. But really, the heart of what we do in understanding what the clinical and financial ROI is, really starting with those clinicians that are providing the care, and then making sure that we can justify the investment from a financial perspective, and that we're going to get the return that we seek out of the investment.
Linda?
Yeah, I think that's exactly the same thing here at Fisher-Titus, really focusing on ensuring that the departments that are going to be using the solution to solve whatever problem it is we're trying to solve at the time are at the initial phases of that conversation. Beyond what Jim said, we would also bring in our cybersecurity team, really important to understand how that AI is protected and set up and tested and validated, et cetera, as well as our compliance department to make sure that they have eyes into kind of what's going on in the organization, ensuring that we're using things correctly and sticking to the standards that we need to remain compliant.
And Jim, a follow-up question for you. You mentioned justifying the investment financially. What goes into that? How do you make sure you can justify an investment in an AI tool financially?
Yeah, so I think that's highly dependent on the tool. Certain tools, I think it's very clear that you're going to see a financial significant ROI with a significant multiplier. If you take a look at something like AI-based coding, clearly there you can reduce your spend on human coders. You'll probably wind up with better revenue capture overall. And then the financial ROI becomes very straightforward. For certain tools like clinical data intelligence tools or ambient listening tools, the ROI gets softer there, right? And so some of that comes down to, some of it just comes down to like, well, everybody else is going to have this and we're not going to be competitive if we don't provide this technology to our providers or our other clinical staff. And so we just have to do it. And we accept that there's not going to be a substantial ROI, financial ROI there. And then there's more sort of soft cases where you can start saying, well, this is actually going to help us with retention. It's going to help us with maybe length of stay reduction, those types of things where the ROI gets a little bit harder to ascertain and at the financial ROI. And we've been very fortunate to be able to work with our CFO and our CEO and all of our colleagues in the administrative offices to understand what's a reasonable expectation from investments in these technologies and really make sure that we set metrics that are appropriate. I give the example of ambient technology here where there was, if you look back at ambient in 2024, everyone was marketing these technologies as, oh, you'll see more patients, it'll pay for itself. And very rapidly, it became clear that clinicians did not want to see more patients, even if you gave them this great technology. And subsequently, we explained that to them and said, look, we don't think we're going to see more patients with this technology. Maybe folks that are underperforming will see more patients, but overall, we're not going to see a lot more patients with this. But everyone is going to have this technology in 1 to 2 years. When we invested, we were very early investors in ambient. So we can either make the investment now with a great partner, vendor partner, and be a leader in this domain and hopefully recruit some faculty and retain some faculty because we're making a clear investment in their well-being by purchasing this technology. But never did we have a financial driver ROI in the acquisition of our ambient technology. And unfortunately, I think that a lot of the AI technologies we're procuring now are enabling us to take care of the caregiver, take better care of patients, and it is an added cost. It's not necessarily a financial ROI other than retention. So.
Excellent. What strategies are crucial to ensuring clinician support when you adopt an AI tool in clinical care? And Linda, why don't you go first?
Sure. I want to add to what Jim just said regarding the ROI, though. I think it is important to track. And like we said, you're not going to get a lot of financial in many cases, but I do want to let people know that one of the things that is to be considered is the fact that we cannot fill positions today. We have openings that we cannot fill, especially if you're in rural America. The people aren't there. There's not enough phlebotomists. There's not enough nurses or not enough doctors that want to come out and work here. So by automating, we're really solving a problem from that perspective that's hard to quantify, but it allows us to maybe do more with less because we can't fill positions, but also to attract people to places they wouldn't normally go if you have the right technology. But to your question, strategy is crucial to ensuring clinician support. And I think that goes back to the very first question, getting them involved in the beginning to, number one, solve their problems. Let's really talk about what problem you're trying to solve. It's, times have not changed in that there are still people that will come directly to a nurse or directly to a physician and say, hey, I'm going to solve all your problems with this solution, whatever the solution is. And it's our job to make sure that it really is going to do what we need it to do, and to really dive in deep with the clinician to understand that. Having them as part of any implementation, getting their input throughout the process to ensure that we're using the tool in a way that makes sense for their work. And ongoing communication is crucial. If you're not talking to them from the beginning to the end and understanding that change management that's gonna hit them, let's look at our nurses. If we're going down the path of ambient scribes for nurses, it changes their work dramatically, where they're no longer just typing as they review the patient in the bed next to them here. They're actually going to be talking out loud the measurements and what they're documenting so that it's captured on the audio and into the AI scribe, which involves the patient and gets them involved with their care. And it's a really great change, but it's a big change. So all of that change management and communication is really critical.
Jim?
And executive support, don't forget that.
Oh, executive support. How should executives engage clinicians when you're doing AI adoption?
I think the most crucial thing we can do as an executive leader, whether you're IT or you're nursing or your CMIO, is to champion it, to show the why. Why are we doing this? So the fear is kind of abated a little bit. There's always this fear of AI taking over my jobs. But if we have the conversation, in my case, about, well, we can't hire as many people. So by bringing these tools in, it's helping you do what you do better with less stress and less time. So the why, communicating the why, being positive, being in the meetings, being at the forefront, being at the bedside with the nurse to support them and let them know, you know what, it's okay. It's going to be hard. It might be weird. We're going to get through it together. I think you have to be there.
Jim?
Yeah, I think our approach to this has been far more problem focused at this point, and identifying where there are gaps that AI can help improve the tasks that we have today. And I think that really helps develop adoption, because it's a tool that people, unlike much of what we've done with healthcare IT, which is we're going to slam the solution in because we have to, right? And you're going to have to use this. Many of these tools we can bring to you to make your life better, right? And this is the first time that's happened in really a decade of healthcare IT expansion. I think there are very few clinicians that I've been in practice for 20 years, and I remember back to the paper days, and I'm one of the last generation that trained on paper. And there are very few clinicians that are like, boy, I'm really glad we got Epic, right? Or whatever your EHR might be, that this made my life so much better, right? It improved the care of patients, and I think the data is pretty convincing that it did improve care. but it didn't make your life better as a clinician. And so with a lot of the AI tools right now, we are able to help make life better for you. And that drives adoption, right? And in fact, what we've seen is very rapid adoption of many, many, many solutions that we've brought into the environment. And then there are people that just like to, you have the laggards, right? You have the late adopters, you have the laggards, it's a natural adoption curve. And those folks, you need to go out and you need to actually convince that this is actually going to make their life better. But I think if you can really address the problem and not focus just on potentially the financial side of the equation, it does encourage adoption of the technology. Undoubtedly, there is going to be technology that is going to end up reducing the number of people we need to do certain tasks. But I don't think we're at the point right now of replacing broad parts of the organization in terms of manpower with AI. Might that happen in the future? The answer is probably yes. But I don't see that happening in the immediate future.
And Jim, how do you address fear that AI is going to be replacing staff members? How do you allay those fears?
I think right now we can honestly say we don't have intentions to replace people, because I think that's a true statement for us right now. There's more than enough work for everyone to do at this point, and really AI is just helping us do the work that we aren't doing or that we're doing poorly and do that job better. Over time, I mean, I think everyone's job is at risk, right? I mean, there are entire industries that disappeared. If you look back historically, because technology evolved. I mean, the horse and buggy business is not booming the way that it once was. Typesetters are doing something else today. It's and we're all at risk for those types of things with evolving technologies. But with that said, I think we have enough foresight with what's coming now that we can come up with good transitions for good people and make sure that they continue to be happy and productive members of our team, regardless of what their job is today.
Excellent. How do you map out adoption parameters? And Jim, why don't you start us off there?
Yeah, I think this is a very good question. And what is success, I think, is really the question here in terms of adoption. And I think a lot of that depends on how much you're spending for the product, how much it takes to support the product, and if it's making a substantial impact for the users of the product. We look at the total number of clinicians that have actually tried a tool and the number that continue to use it after trying. If you're paying on a per head basis, and it doesn't take very much to support it, you can have a tool that maybe only 10% of your population is using, but they love it, and that's an important tool to support. For something like ambient, where it's expensive, and we did an enterprise license, there we really need to make sure that people are using the technology, right? And that they're not using it, understand why they're not using it, and then make a decision at the end of the contract period as to whether or not we're going to right size that license, or maybe we don't have the right technology, acquire new technology, whatever it might be. Just as an example, we love our ambient vendor. We have no intentions of changing right now, but But those are the types of questions and calculations that we're doing. I think it does take good analytics that many vendors don't really supply well and are difficult to ascertain with your own internal user data. And so an analytics strategy, I do think, is something you should probably scope out when you start rolling out these products to understand their utilization, and then some thresholds as to what's going to trigger action, and probably defining those before you ever start is a important exercise for you to participate in, rather than figuring it all out later.
And Linda, how are you mapping out adoption parameters?
So it does depend on the solution we're talking about. So for example, in our area of our case managers, or utilization review, I should say, actually, they're required to use it. It's part of their job, and it's helping us to drive throughput, et cetera, from an inpatient perspective. So adoption would be, we monitor the usage and ensure that they're actually following the process, which is where we would depend on the analytics, et cetera. However, in some areas like ambient, in our case, we don't go down the path of requiring some of these things. They are additional tools that you might use to improve your own experience. In the physician's case, we have physicians that are faster on their templates because they have spent years developing templated things that they can easily default information into and very quickly use. But we do monitor who's using the ambient solution, the quality of the ambient solution that they're getting and the notes that they're getting, because that's just as important, not the frequency, but the quality of the work. So we do monitor that to ensure that, do we have the right tool for the right people, and are we spending the right amount of money depending on what we're getting out of it? So all of those factors come into play.
In the second part of this question, how many clinicians need to use a new tool, and how often to ensure sustainability?
I think that depends on the tool and the type of contract you have. And Jim had mentioned that he had an enterprise. Obviously, that's a larger cost, an enterprise-wide. So you would want to set a lower threshold. And if we're not getting that lower threshold, we need to rethink whether this is the right tool for us. In those cases, we might sign shorter contracts just to make sure we're not locked into something that we're not getting the adoption for when we need it. In other things, our ambient scribe is per use. So it's not as critical for us to say, I need 20 doctors, 100 doctors, 1,000 doctors to use the tool. What's more important is the quality we're getting out of it and the productivity that they're experiencing. So again, depends.
And Jim?
Yeah, I think that's exactly the situation. I think it really depends on your contracting and what those thresholds are. I do think that the idea of shorter contracts with all of these technologies is a really good idea right now. The market is evolving very quickly, in addition to the fact that I think that so far we've been pretty good about guessing what's going to be a hit and what's going to be limited utilization, but you never know when you're going to get that calculation wrong and be on the hook for sizable expense without a lot of upside. And so the ability to just walk away from something that's failed is, I think, an important one.
And I can tell you an example of that. An example of that is, I've been here at Fisher-Titus for 7 years now. We've been through 3 ambient scribe solutions in that time, because we continue to see improvements. We continue to see cost savings with different ones being offered, so that sustainability is different than it used to be. We want to be nimble and be able to switch when needed.
And what went into your your adoption strategy as the AI scribe technology changed? What were you looking for in terms of advancements in technology that made you want to make the jump to a new tool, Linda?
Sure. And I think that changed each time. So for the first one, it was cost. The cost really started to come down. We were originally with a vendor that was really new to the market at that time, and it was expensive. So when we saw that prices were coming down and experience was not degraded, we switched over. And then the second time we switched over was more around the fact that the AI quality was not as good with the first one or the second one versus the third one. So we really went down the path of saying, okay, our doctors are happier with the results that they get of this new one. And we did a little bake off. We had several doctors use multiple tools and tell us what they preferred. So that's how the last change went.
Great. What benchmarks are studied to determine how and when to scale a new tool or platform? And Linda, why don't you start us off?
Sure. And I think a lot of that's what we've talked about so far, right? For me, the benchmark has been satisfaction with the tool, quality of the information you're getting out of the tool, because that seems to be one of the things that's inconsistent at this point. Not all AI is created equal, right? So the department using it, the clinicians using it really need to let us know that I'm seeing really good results and accurate results with one tool versus another. So I think that's the first thing we look at. And then the second thing is, can we afford to scale to a large degree with whatever tool it is? So we look at the cost as it's rolled out as well. But quality would be our first.
And how do you monitor quality and verify it?
That's a great question. And I know at some point we'll get to governance, but one of the things we set in place for our AI governance is the fact that the departments that are involved with the use of the tool, whether that's quality from utilization review, nursing, physicians, we're expecting them to be monitoring the quality and let us know in terms of what's validated, what's not working, what's hallucinating, because your IT team's not going to know that. We don't have in rural healthcare, we don't have a team of people sitting here validating AI content. So we're really counting on feedback from the clinicians to let us know how that's going.
Jim?
Yeah, I think the quality discussion is an important one. I think there's also, at the end of the day, a lot of these tools are provider facing and are designed to make their lives better. And so we are highly dependent on actually user survey data, and not just of the tool, but of how the clinician is doing overall, right? So looking at our Press Ganey data for engagement and how our teams are doing in that. Did we implement a new technology that seemed to correlate with a bump in that, or is mentioned in the comments? We also put a lot of stock in an IT-centric survey. The Arch Collaborative, we put a lot of stock in the movement, whatever the vector on that looks like, and the feedback from our clinicians as to whether or not they think those technologies contributed to improvement in their overall digital experience. Obviously, you need to have the finances aligned, and if the technology isn't delivering as promised, even if people love it and it's providing bad care, you need to remove that technology from your portfolio. But we really focus on those things. What's it doing for our clinicians? What's it doing for our patients? How do they feel about it? Really in that order.
I would add to that, Chris, that integration is really important as well. We might pilot something that's, to see how that integration goes if it's newer to the market. How does it integrate with your electronic medical record or their workflows? But the easier and more thorough that integration is, that would allow us to scale up for ease of use.
And how do you judge that integration? Is that something that you work with your vendor on, or is that something that you determine as you're adopting an AI tool how smoothly the integration goes with your EMR and your clinicians' workflows?
We certainly have that conversation with any of the vendors that we're working with from the start. All right, we want to understand that. But when you're piloting, you might not put 100% of your effort into that integration because you're not going to know how far you're going to go with it. But at some point, you have to have the ability to see. They always say it's integrated, all right, but is it truly seamless to the clinician for that information to come through and flow directly into your EMR without having to cut and paste or do something special to get the information filed correctly? So you kind of have that conversation all the way through, and then you test it during your pilot.
And Jim, you mentioned, I think it was you, maybe it was Linda, someone mentioned the cost of scaling being one of the parameters. Okay, yeah, Linda, you mentioned the cost of scaling being one of the parameters to decide whether to scale a tool or not. How do you assess those costs?
Well, it's interesting, especially in rural healthcare. We struggle with pricing in any of our purchases because we don't have the large volume of staffing and physicians, et cetera, that Jim might have. So we might start at one place and think, well, we're going to gain this much interest, however many people that is. And then we find out we're really going to need a lot more of those. And how can we scale the pricing down? How can we pull from somewhere else to accommodate that? But you think you know where you're going to start, but through the pilot, you really understand how much interest there truly is, so you know what you can afford to go forward with. I know it's an unusual circumstance for many. I'm sure that's probably not a conversation that Jim's organization has, but for us, it's common here.
And in that pilot phase, how are you monitoring costs? Again, thinking ahead towards scaling a tool.
Usage. And typically it's usage. Yeah. A lot of the times we're trying to negotiate contracts, short-term contracts, like we mentioned, but also I want to pay per use, or I want to pay, for example, some of them, if they were monthly per person per month kind of cost, if I'm not getting enough adoption, that's another decision, because I'm paying per month and you only used it for a limited amount. So I'm not really getting my money's worth out of your usage, if that makes sense.
Sure. Next question. Who helps develop governance guidelines? And Jim, why don't you start us off?
Yeah, so regarding AI, we really took a very streamlined approach to governance. A lot of healthcare organizations have stood up separate AI-based governance that really starts at the conceptual level of what type of tool are they going to introduce. We treated AI, for the most part, as just another IT tool. So it uses our conventional IT acquisition processes. Someone sees something that they're interested in, it goes through the same acquisition process as everything else. The one thing we did do was we created an AI oversight group that, as things work their way through the process, we have a group that does have some additional training in AI that are both clinicians and IT staff, and obviously, and they'll look at the AI for some sort of novel things that we need to look at, performance characteristics if it's a predictive model. If the organization is using generative AI, we want to make sure that they're not training on our data, so our information security office is engaged there. And then that group is really charged with saying, yes, the AI meets sort of a standard for predictive modeling, for the security things, for the way that the model was trained, that we think it's appropriate for use in our patient population. And then it returns to the standard purchasing process as it goes through. So there's this little bump in the road that we put in for AI. And then over time, particularly for predictive models, We do have that group charged with revisiting those models, and reviewing the drift analytics and those types of things to make sure that the models are still performing over time. Just because turning that over to the end user, they may not really understand, what precision recall curves are and other things like that, and how to understand what's going on with a model. So that's the other thing that AI oversight group does, but it's very lightweight given the amount of AI we've brought into the organization.
Linda, who helps develop governance guidelines at your organization?
We're very similar. I've said from the beginning, everybody would first ask me, what's your AI strategy? I'm like, I don't have an AI strategy. I have a strategy. And AI is one of the many solutions that become part of that strategy to solve many problems, whatever those are. So our governance is very similar. We have always had a governance process. We call it systems oversight. And AI is on the topic, just like any others, goes through that process, through the discussions. It goes through a cybersecurity assessment, including a questionnaire around AI. And everything gets approved just like anything else would be approved. We have an AI inventory then that would respond to what we have out there, monitoring that. Do things pop up that didn't go through governance? Yes, because there's those free things out there that people find and love and start using. And then we have to kind of route it back through governance to have that discussion. So it is continuous and it's ongoing, and it's hard to keep up with it. But we have, just like Jim, we have one system oversight that covers everything. We do not have a separate committee that works on validation or topics like that. That goes through the same committee for us.
And when you say you have one system of oversight, is it like Jim's, where that's for all IT tools?
Yes. Mm-hmm. Yep.
And then you hit on the next question, Linda, which is ensuring that governance is continuous. Give me some more detail about how you're doing that.
Yeah, so a couple of things. Like I mentioned, we have the AI inventory, which we can reference at any time, and we have AI update. Even if there's no new thing to come to committee, we have an update that goes to that group on a monthly basis. And then actually other pieces through contracting. So we need to watch contracts as they renew, revisit that conversation with any technology that's waiting for its renewal. Have you changed anything in the way you build it, maintain it, where it's housed, all those other things? That's your opportunity right there to ask the questions again and ensure that we're doing the right thing is at that renewal time. So that kind of helps us with that continuous process as well.
And Jim?
Yeah, as we sort of alluded to, that AI group really does the ongoing AI governance for the organization, with looking at our models looking at models that have been acquired on an annual basis. And obviously, when we come up on contract renegotiations, we may have a little more in-depth discussion there about, are we getting the ROI that we expected, those types of things. But again, that would happen with any product that we have in the organization, whether it uses AI or not.
And who specifically is serving on this AI oversight group? Can you give me an idea of the kind of staff members you have there?
Yeah, so we have myself, we have one of my associates, we have our Chief Information Security Officer, we have our Chief Information Digital Officer, we have actually a geneticist, because we do see that there's going to be a lot of genomic data that's going to be used in the AI domains. We have one of our research IT folks that has a focus in AI as well. And our Director of Application Services. So that it's an IT heavy group, but it does incorporate people from other domains that really round out the group to help provide that knowledge. But all of them have had additional training in AI, whether that be some relatively low-level certificate type work or, full-fledged degrees.
Excellent. Next question. What has surprised you, good or bad, about launching a new AI tool for clinical care? And Linda, why don't you go first?
So surprise me, I don't know, it's kind of nothing surprises me anymore. I've been in this business too long. But I would say a couple of things that I may not have thought would be so prevalent would be the changes, the understanding that not all AI is created equal, and the quality, various quality of that, I think has surprised us from organizations we would have thought would be amazing, maybe aren't so good. So that was kind of a new thing. The lack of understanding of AI and what it can do is another one that I think surprised me, not good or bad, just, you need to get people to the table and get them understanding what this is. And we have done education, but that doesn't mean they're kind of really thinking about it. And the last thing is the huge change to our contracting process. I would say that gone are the days where you'd sign a 5-year contract. At this point, I don't know if I've even signed a 3-year contract because things change so fast. It's really changed how we do that work. And like I wanted it for 1 year, and because of the way the integrations work, it's generally very easy to, like I said, I've had through three different scribes, and one of them, was up and running within a month, and the doctors just had the app and started using it without any training. So it's really changing the speed of which we do some of the work that we do.
And Jim, what about you?
Yeah.
What's surprised you, good or bad?
Yeah, so I think what surprised me most is the willingness for providers to adopt these tools. If you introduce a new feature in your EHR, you're like begging and pleading with people to try it and do these various things, and people really, you see very poor adoption of many new features, much of which I think are because they don't actually contribute that much to making the provider or the patient experience that much better. They're small incremental changes. Whereas AI, when you turn on some of these tools, they are game changing for providers. And there is a large group that will start using these things on day one. And they're very easy to use, at least the ones we've chosen to implement. And so the training requirements are much lower. There's not begging and pleading to get to that kind of sustainability in terms of number of users very quickly. And I think that's different. And it surprised me. I thought this would be easy to sell. I didn't think it was going to be this easy to sell. With that said, you'll get, we'll get this kind of 50 or 70% of people using the technology. What's also been a surprise to me is that recalcitrant group that doesn't want to adopt it, that doesn't want to try it, right? I mean, it's almost, that surprises me, right? So what we've seen is this kind of a very rapid adoption curve that's gone up and then plateaued and gone very slowly. And I would have thought that we would have gotten basically everyone in a discipline where these tools would help using these tools. And what you're seeing is a dichotomy of, folks that love the tool, couldn't exist without it. If we took away, they would quit the next day. And then a group of people that say, I never want to touch that. And it's just been different from what you've seen with other technology adoption historically. So that's been the biggest surprise to me.
And what do you know now that you wish you would known earlier? And Linda, why don't you go first?
So I think that what's been difficult, and I wish I had known earlier, but it's impossible, is there's AI everywhere, right? There's third-party solutions, there's your EMR solutions, and it's hard to keep up with the roadmaps, right? So all the different things that are coming through our EMR, for example, we've been looking at third party because we don't know the other one's doing this and who's doing what and how are they getting there fast enough. How are we keeping up with their roadmaps? I think that's what I wish I would have known earlier, because I might have made different decisions along the way to do things or not do things. It's impossible to know that before they tell you, but it's that's the first thing. And I think the second thing would be, as Jim said, this is going to change even our training programs, because typically these things are being rolled out in a very easy way that they could just pick up and adopt, which is a blessing, but a change to how we roll things out. So, we're learning as we go along.
Jim?
Yeah, I am going to agree with Linda here. I wish I had known just how chaotic every vendor's roadmap was going to be. Mm-hmm. We made certain decisions based on the fact that our EHR vendor said certain things, and next thing you know, 18 months into the AI fiesta, that's totally changed. And so now you have legacy product that we're very, very, very happy with, but you're busy wondering how does that fit with what your EHR vendor is going to do. And you're not just wondering how it's going to fit today, you're wondering how it's going to fit even in as short as 3 months from now, right, with what they might be rolling out. And that makes it very hard to come up with an articulated implementation plan and rollout plan of what you're going to offer. And not just from a contracting perspective, but how you're going to educate people to do things, right? What tool are you going to encourage people to use right now to solve this problem? Because you may have 3 tools at your disposal from 3 different vendors that are all targeting the same thing in 3 months. And that gets really hard, right? And I wish I had known how fast things were going to change, really. Not that it would have made us do anything differently. I just would have been ready for the ride. So
yeah, clarity would be nice, right?
Yeah.
And how have you risen to that challenge of the technology changing so quickly? And Linda, why don't you start us off?
It's tough. I don't know that we just stay open to change, and stay close to the other department leaders who are the recipients of that change, so that we can work together to take advantage of whatever improvements are coming, whether that's changing out one AI scribe, putting in another AI scribe, whether it's adding functionality in as quickly as we possibly can. For example, ordering automated through your ambient scribe solution. So the only thing to rise to the challenge is stay close to your people, communicate, and watch your roadmaps. See what you can take advantage of tomorrow that wasn't available yesterday.
And Jim?
Yeah, I think, as Linda was saying, I think it's really finding vendors that are great partners, mm-hmm. right? That will at least tell you what they're thinking and give you some projection as to what the future holds for them. And if you have that open dialogue, you can at least be ahead of knowing that there will be 3 similar features from your existing vendors, and then you can start to think and test and come up with a plan regarding which of those you're going to implement and solve a particular problem. If you have a poor relationship with your vendor and they surprise you with a bunch of things, that makes it really hard, right? So to me, it's, as Linda said, know those roadmaps. I think the best way of doing that is having a really good partnership with your vendors.
I would agree.
Great. Last question. What happens if a new program fails to meet expectations for either clinical or financial ROI? What do you do then?
Go ahead, Jim.
Well,
Sorry.
yeah, I think the first thing is that you really, I think when you're spinning up a program like this, you need to do at least a proof of concept and have some and a pilot and have confidence that you're not going to have to walk something back. And then if things are not meeting those kind of expectations, obviously you're faced with the remediate versus just step away from it dialogue. And in general, I think remediation is probably better, assuming the product is delivering as you anticipated it would deliver. Technically, it may be an adoption problem. And then if it's technically not performing, then I think if you have a product that's not performing, you can spend a little bit of time trying to make it work. But if you're working with a vendor that you can walk away from, I think you should just walk away from them. If you were sold snake oil, I think you just say, I'm done, with the snake oil. We're going to find somebody else. And you look for a reason for the contract to be terminated early with potential damages. We haven't had to do that, but I think if you're buying something that's half-baked and it wasn't sold to you as half-baked, you have a reasonable expectation that the technology should work.
I would just add two key things. Your workflows and adoption are everything, making sure that you've got your leaders in those areas that are going to help you to ensure the appropriate usage, because that doesn't always happen. And your vendor partners, we're back to the vendor conversation. So if you have a good vendor that you develop relationships with, you're going to be able to have the hard conversation. Look, this is not doing what we intended it to do. Ideally, this doesn't always work, but ideally you write the ROIs or the results or whatever it is you expect to do into the contract. So if you're not achieving whatever it is you need to achieve, you have that ability to get out, whether that's seamless integration or ROI or adoption levels, and then they're partnering with you to achieve those things. And then you have the ability to make an effort to fix and or a clear out if you need to. Timing wise, I don't know if it's a year, it's hard to say, depends on the tool, but that's really how I would go about it.
So having that ROI set up front gets the vendor on board with you meeting that ROI?
Yes, exactly. They're not always open to that, but it's something that I would definitely try to do if I can.
All right, then. Thank you both, first of all, for excellent discussion. This now brings us to the Q&A portion of the program. So we would now like to invite you in the audience to ask live questions of our panelists. As a reminder, if you are participating in the live program, to submit a question, click on the Q&A widget at the bottom of your screen. It may be open already and appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewed by other audience members. So the first question is, how can you avoid risks in AI tool adoption, such as cybersecurity, not meeting ROI? How do you limit your risk in AI tool adoption?
So
I'm sorry, Jim, why don't you go first?
Yeah, I would say that there's always going to be risk in any of these technologies, and it's about mitigating your risk as much as possible. And so on the cybersecurity side, it's about doing a good cybersecurity review, making sure that the vendor obviously has a substantial amount of cybersecurity insurance. If you're going to be the first doing something with somebody, obviously you're going to need to do more due diligence into what they're what their cybersecurity profile is than if they've sold to, 6,000 hospitals and you're going to be 6,001. And in terms of adoption, again, I think with these tools, if you are bringing tools forward that solve problems that your clinicians have, you will have adoption of these technologies. This is not like these are not like other technologies that we've introduced into healthcare, where people need to be convinced to use them. You will have adoption of these technologies. Will you have everyone using them? Probably not. But will you have enough people using them, and will the organization know about them through word of mouth? The answer is yes. So.
And Linda?
To the risk question, I would just add that there will always be risk, as Jim said. This is no different than risks we've had over the years when we implemented the EMRs and CPOE and all the other things for those who in the industry that far back. There was risk then too. Risk that they didn't document clearly in their note. Risk that they didn't, document something that they should have. There was risk then too. So the bottom line is the clinicians, whoever they are, still have the responsibility to ensure that that's accurate information. So from a clinical standpoint, the risk is different, but I don't know that it's worse. We just still need to pay attention and be responsible.
And I like this idea of clinician responsibility, for making sure that the outputs of the AI or the documentation that the AI is producing is accurate. How do you ensure that clinicians play that role?
Well, this is human in the loop, right? This is the person who has the AI tool that they're using is signing off on that document, whatever it might be, whether it's a doctor, a nurse, or whatever who's using it. They're signing off that the information is accurate. And this is their license on the line, their job on the line. So they need to be reading, understanding, and become responsible.
And another question, if there's one or two key takeaways from this presentation, what would they be? And Linda, why don't you start us off?
Oh gosh. As a CIO, I'd say try to stay ahead of the game. It's hard. Partner with your vendors, try and learn what's out there, because I think that it's hard for the rest of our organizations to keep up. So I do my very best to bring solutions, bring ideas on different solutions that can be a benefit to them. So stay ahead of the game and communicate with your teams.
Jim?
Yeah, I would say that the biggest thing is stay focused on the problems that you're trying to solve, just as you always have. These are new tools that enable you to solve problems differently with far more capability than maybe many of our tools did in the past. If you continue to focus on solving problems inside your organization, many of the barriers that you've had with implementing other technologies, because of the degree that these tools solve problems relative to tools in the past, you'll have good adoption, assuming you choose, as Linda said, good vendors and you partner with them appropriately, and that you're aware of what the market is bringing forward. So.
Great. Well, again, I want to thank both of you for an excellent presentation. That's all the time we have for questions today. In closing, please note that our next Winning Edge program on April 21 will cover the Winning Edge for remote patient monitoring success. A live clickable link will appear at the close of this program, taking you to our registration page for the event. Remember to follow along all week for continued coverage on strategies for clinical AI advancement by visiting our website, healthleadersmedia.com. And finally, thank you to you in the audience for participating. We hope you enjoyed today's program and look forward to seeing you during our next Winning Edge program on remote patient monitoring success.